These are the latest published guidelines by Yauk et al., published in 2013. And we're going to go through them in a minute. But I want to just read this fine print, which most people don't really read. Under some circumstances, with careful consideration and weighting of risk to benefit, patients may receive fibrolytic therapy despite one or more relative contraindications. Consider risk to benefit of IV TPA administration carefully if any of these relative contraindications are present. Caution. So these are the things where they're saying, use your judgment. Minor or rapidly improving symptoms, pregnancy, seizure at onset, major surgery or trauma within 14 days. And I want to emphasize the time period, which are totally arbitrary, 14 days. GI or GU hemorrhage within 21 days. MI within 3 months. These are arbitrary time limits. Use your judgment. No longer mentioned is anything about severe strokes. That's no longer even considered a caution. These are the things where caution is not advised, which are considered contraindications. But again, read the fine print. A physician with expertise in acute stroke care may modify this list. Okay, so in my opinion, the things to modify are these time limits. Why is it 3 months that we wait after head trauma or prior stroke? Totally arbitrary. Arterial puncture at a non-compressible site, 7 days. Arbitrary. No history of previous intracranial hemorrhage? What if somebody had a spontaneous hemorrhage 20 years ago due to uncontrolled hypertension and now is on has atrial fibrillation, not anticoagulated, and has a major stroke, ischemic stroke? Intracranial neoplasm? Or what about a meningioma? What about an aneurysm that's been secured? Platelet count, 100,000? I mean, most hematologists don't blink at a platelet count above 50,000. Blood glucose less than 50, true, but what about elevated blood sugar? So anyway, the point is judgment. Now, what about the package inserts? For those of you who like relaxed criteria, the package insert can be very reassuring. Current intracranial hemorrhage, well, duh, nobody would treat somebody who's got blood in their brain, although, who knows? Subarachnoid hemorrhage, active internal bleeding. Well, I think Genentech is pretty safe on those, and most of us in this room would not treat somebody who has those things. Recent within 3 months intracranial or interspinal surgery or serious head trauma. Actually, I ran this one by my neurosurgeons. The consensus of the neurosurgeons in my center is that if the surgery was for a non-vascular lesion, like a tumor, not an AVM, and not a vascular lesion, but a non-vascular lesion, and there was good hemostasis, they see no reason to wait 3 months. They think 3 days is more logical. Presence of intracranial conditions that may increase the risk of bleeding. Some neoplasms, AVMs, or aneurysms. Bleeding diathesis. Notice no mention of an INR level, and no mention about patients on the newer drugs or on warfarin. I'll come back to that. And then current severe uncontrolled hypertension, but again, no thresholds mentioned. When the insert goes on to say that should be weighed against the benefits in these other conditions. And here we talk about elevated blood pressure, recent trauma, and all these other things that were considered contraindications. So again, the point I want to make is that in the package insert, it's allowing room for physician judgment. So we are emerging to an era, in my opinion, where TPA is given not by a checklist, but it's used routinely within 4.5 hours unless there's an obvious exclusion. So, in questionable cases, its use should be weighed against the benefits. So, in questionable cases where it's a very mild stroke, then usually it's not necessary to take the risk. So you've got somebody with an NIH stroke scale score of 3, and they've had a previous hemorrhage, or their INR is a little bit elevated, their platelet count is low. You're not going to take a risk in that patient because they're probably going to have a decent outcome. But if they have an NIH stroke scale score of 15 or 20, you're going to likely end up in a nursing home that's a patient you may be willing to take a risk on. And in patients with those patients with more severe strokes, as we'll hear in the next talk, we now have another option in these cases. So the patient with a severe stroke is likely to have a large artery occlusion. That patient who's got an elevated INR, or who's pregnant, or who has other relative contraindications, you may omit the TPA of that patient and take the patient directly to endovascular therapy. So we are having more and more options, and there's more room for judgment. Now, the final shoe that's dropping, at least the most recent shoe that's dropping in the who qualifies realm, is this publication on which I'm one of the co-authors. I was kind of the senior guy that was supposed to look at what all these people said and say, does this, what do you think? And so I do take responsibility for what's written in this paper, which I think actually is a great paper which reviews all of the literature on each and every one of the contraindications that are usually considered in the emergency department. It was published in Stroke just about 2 or 3 issues ago in volume 47 in early 2016. And I don't have time to go through all of them. I will just go through a few of the things that were mentioned where I think we're going to see some changes over the next few years. So, what about stroke severity? So, what they say for severe stroke, as I pointed out, TPA is indicated class 1 level of evidence A. But where the questions come in are for milder strokes. So what they say is patients with mild strokes but who have disabling stroke symptoms, ITPA is indicated, class 1 level A. So that patient with a low NIH stroke scale score who would be disabled, even if it's a low NIH stroke scale score, on the basis of that deficit, that patient should be treated. Where the data is less evident, class 2B, level of evidence C, are in milder symptoms that are judged as non-disabling. In those patients, TPA may be considered. And there is room here, equipoise, and a trial is being carried out, the PRISMS trial. This is where we are going to get new data, hopefully, in the next few years. Patients with mild strokes, which includes patients who have persisting mild deficits or who are rapidly improving from a severe deficit to a mild deficit. The NIH stroke scale score has to be less than 5, and that those 5 points have to be considered non-disabling. Those patients are being randomized to TPA or placebo. You might say, well, why treat those patients if it's non-disabling? Well, 30 to 40% of those patients are going to deteriorate from a non-disabling state to a disabling state over the next 24 to 48 hours and may benefit from TPA. So this study is ongoing, and we should have data, hopefully, in a few years. And those of you who are practicing in centers that are conducting this trial, please enroll your patients. Okay, what about the 3 to 4.5 hour time window? This is interesting. As you know, there are a number of relative exclusions from ECAS 3 that were applied to patients in the 3 to 4.5 window. One of them is patients over the age of 80. Well, recent data from the IST trial showed that patients over the age of 80 benefit just as much, if not more, than younger patients. And so the paper that I just referred to, the Demarchuk paper, says that TPA is safe and can be effective as in younger patients, and they gave it a 2A level of evidence B. I would have given it a stronger recommendation. To me, I don't think there's any evidence now to exclude TPA on the basis of age alone. Another relative exclusion is patients who are taking warfarin but whose INR is less than 1.7. This is, again, the 3 to 4.5 hour time window. Again, safe and may be beneficial. So if the INR is low, even though the patients had been taking warfarin, TPA can be given in those patients. Where they tend to be a little bit more equivocal, evidence C, is in patients with a very severe stroke. Baseline NIH greater than 25 in the 3 to 4.5 hour time window. Again, these are patients who are going to probably harbor a large artery occlusion. It's not that TPA shouldn't be given in those patients. Again, I'm not sure this deserves a level of evidence C. I would say B, but they say it's a little more uncertain in those patients. And then finally, the other ECAS-3 exclusion is prior stroke and diabetes in the 3 and 4.5 hours. And the wording here is may be a reasonable option. Class 2B, evidence B. So again, judgment. Okay. What about pre-existing disability? You know, in all the clinical trials carried out to date, the NINS trial and all the endovascular trials, patients with pre-existing disability were not allowed to be enrolled in those trials. They had to have a baseline Rankin score of 0 to 1. Well, I'm running out in my mobile stroke unit. If someone has a stroke, and I'm finding that 20 to 30% of patients with strokes have pre-existing disability. Patients with previous strokes have more strokes. Patients who are elderly, who are disabled from arthritis or congestive heart failure or other problems, they represent a large percentage of our stroke population. These guidelines say patients' baseline Rankin score is greater than 2, treatment may be reasonable, but class 2B, level of evidence B, you know, I don't think we have any data whatsoever that says that these patients cannot benefit. And Dr. Al-Maghrabi from our center is presenting some data on the 21st, I can't remember what day of the week, that's Thursday, a poster on the outcome in our patients on the mobile stroke unit who have baseline Rankin scores of 2 or higher. But bottom line is, at least for this paper, decisions should be taken into account relevant factors other than Rankin score, including quality of life, social support, place of residence, deep recovery, blah, blah, blah. So someone who's already a Rankin of 5, who's bedbound and has a miserable quality of life, and the family agrees and has an advance directive, you know, maybe you're not going to treat that patient. But the patient who's walking independently has a Rankin score of 2 or 3, or even 4, and is cognitively intact, why should that patient not be treated? So we need more data on those patients. Okay, history of anticoagulant use. And patients with direct thrombin inhibitors or direct factor 10A inhibitors, it's not recommended unless laboratory tests are normal. Well, we know that the appropriate laboratory tests that measure the activity of these drugs are not available in the emergency room generally. So unless the patient is 48 hours from receiving them, we can't give TPA. Well, we know that patients with receiving dabigatran, Xarelto, and apixaban that are more and more frequently used and we're being seen, and we now have reversal agents. The reversal agent for dabigatran irreversibly binds dabigatran within minutes, and we have already treated one patient with TPA who came in, had received dabigatran that morning. We gave them the reversal agent and treated them 10 minutes later with TPA without any problem. So I think that this is another area where there's going to be progress in the next few years as reversal agents become available. I think this waiting 3 months after a previous stroke, this is one area where I disagreed, another area where I disagreed with this paper, and they said that it may be harmful. Oh, yes, it may be harmful, but it could be harmful to anybody, and I think the operant issue is the 3-month wait. To me, it makes no sense to wait 3 months after a stroke. I would go by when the blood-brain barrier has been reestablished. If there's no more swelling on the CT scan and it's several weeks, why should we not be able to give TPA in those patients? But at the end of the day, they say the potential risk should be discussed during thrombolysis eligibility deliberation and weighed against the anticipated benefits during decision making. But this is another area where I think there needs to be additional work.